have seen, and I have done in some of the cases, not every case, I do more of tongue reduction nowadays instead of distraction in pediatric cases. You can do even 4 millimeter on the table distraction. Because the table is so high in the pediatric neonatal, the healing is very fast. You don't have to worry about not healing in a pediatric group. So instead of 1 millimeter, you can go up to 2 millimeter. Faster, overall is very good. Function achieved is very good. Specifically, in a very short mandible, you want people to wear in a very fast way in a period sequence. That's best. Now, this slide also shows you what are the different type of latency you need. Of course, this presentation you can access after the course I hope. Dr. Ethan team and Dr. Aviation team give access to all these things to go through it. So what is very important, see, it's almost the same that electricity in almost all the cases. Minimum 4 days to 7 months. Some cases, children can do 2 to 3 days you can start to track. Rate, as I said, 0.5 to 1 millimeter, but I said 0.5 to 0.5 even better. Less it should be more tolerable, less pain. Okay? And depend upon what you want to do. Conservation period. I can still say 8 weeks to 3 months for maximum mandible, then up to 6 months for radiation spread conservation period. Is there a difference between fracture and distraction? Yes, there is a little bit of a difference. Because normally in fracture there is the animation tissue forms, fibrosis, then the nature of open bone, then the open bone to laminar bone. But in distraction, if you see, there's an impact here. You are intensely producing a fracture, bicortical fracture. Then you are applying a distractor. Then there is a slow pull happens. So there is inflammation, soft tissue, gradual fraction, form, later hard tissue, then the removal. So there is a little difference between this and that. Remember, you can go to before I go to real indications. What do you can do? What direction? The question is always that whenever you have whenever I have a distractor, how do I use it? Where do I use it? That is very important to understand. So what is called a vector? What is vector? Vector means the direction in which you wanted to move the bone. Whether it can move vertical, horizontal, or oblique, or transverse, like this, transverse, okay, horizontal. You can move it in what way, depending upon the type of distractor what you want to do. But you see the line on the top, that is a vertical. A line, vertical, you can increase the length of the ramus. Only vertical. The B, the line B, is showing what is called as the oblique in the mandible, that is from upper perineal area to lower angle of the mandible. So what happens in this case is that there is an increase that can happen both in the height and the length of the angle. And the third one is of course the C, where it can move horizontally alone. Without increasing the height of the ramus, you can lengthen the body of the ramus. So this is called as the vector of the brain. So remember, these vectors are also influenced by the muscles around the bones, straightening of the ramus. Remember again, the vector also is being influenced by the muscles around the ear. So these mechanical vectors sometimes you have to know that how do I decide where to put the distractor on an osteotomy site. So you have an osteotomy site, you have to put a distractor and put it in the function like this. And that is what is important. Putting in the right way. You can't make an osteotomy cut and put a distractor like this or something. The direction may not be good. That is also very, very important to understand. So if you know what direction you want to take, you have to plan the distractor placement then. And that is something which is very, very important. Either for internal or for external. You can have a minimum deviation of about 20 degrees, not more. Minimum deviation. Otherwise, it has to be 100% perpendicular so that the distractor can move the board can separate the ideal direction what we are looking for. What are the type of distracted devices? Now, what is the difference here? Now, in an osteotomy, normal osteotomy, your maxilla is brought forward, mandible is being moved wherever you want to use a plate and screw fixed immediately by using an intraoral spring. Job is done within 2-3 hours. You have done, move the jaw like a leaf or one or surgical strip everywhere, fix it. Here, you are using a distract, which is an external or internal distractor, very important to understand. There are two problems I have found with it. Is the decision making. Okay, decision making. Certain cases you can go for an internal distractor, patient doesn't want an external one. Yes. There are certain indications, for example, if you want to do a conceived small distractor for a V41. Yes, you can go for a V40 internal distractor. If you want to have a large movement, you can go for a rigid external distractor. So you have so many distractors, external, internal, subcutaneous, intraoral, submucosal, extramucosal. All these are the textbook you can go to. Okay? So now based on relation to skills, there's an external distractor, internal, some of them are worried, some of them are semi-worried. What you see in the first picture is an external distractor. What you see in the second, the two bottom pictures are distractors which are purely based on the basis of teeth. That is the distractor internal, but a tooth one distractor, fixed on the tooth. So there's a bone distractor, tooth bone distractor, there's a hybrid as well. So you have so many varieties of distractor. Now this is one example is what you can see here. If you want to transverse distraction, transverse on the model you can see you have 4 screws on the distractor which is being kept ready. You can put the screws on the parallel and if you distract it, you can transverse widening of the maxilla. So this is like a hybrid. And another one is a tooth-bone distractor. This is another one hybrid. You see here what happens here. Here, part of the distractor, intraorally, part of the distractor is external. This is very useful in certain cases like mid-phase distraction of the mandible. Mid-phase. You wanted to put a narrow mandible, you want to distract it, you can use this. So that is also very important to understand. So you can have, so the plates and other screws will go inside the mucosa, activation of it come outside the mucosa on the data. So this is called the hybrid distractor. Now what are the type of distractors? You are moving only one direction, like this. That's called the uniform. You are moving in 2 directions. Bifold, I will come and then there is trifold. Okay, now let us see here. This is unidirectional. We are moving in only one direction, either horizontal or vertical. You can see here there are 2 osteotomic concepts here. One at the right, one at the bottom, almost diagonally. You can move, we use a direct distractor in this case. You can distract, you can move, vertical move as well as horizontal. So this becomes a bidirectional for 2 directions, bidirectional distractors. First one was only one direction. It is both the 2 directions done. And there are multi-directional distractors. That means that can come down, can come forward, you can move left, everything right. So all directions, this is multi-directional distractors. So all type of distraction devices are there. A good distractor, also available in India, some companies make it. Also available if you want to buy outside, it will be very expensive, but very reliable and you can use it as many times as you want. So, as I already mentioned, vertical vector, horizontal vector, oblique vector, which is very important. What you see here, for example, is a classical example of a maxillary internal distractor. You move the maxillary anteroposteriorly. Remember, what distraction cannot do is to impact the maxillary. You cannot do it. There is no question of compressing the bone. Internal distractor, What are the problems with the distractor? Once you place it, like this, for example, in the maximum, there's only one movement. In case like what I have been shown, it comes only forward. Only one movement. Even if you have a small open right, you can put some elastics and then close it with the ideal elastics. But the movement is only one direction here. So this is the biggest problem with certain internal distractors. But if you see this, what I showed you with the multi-level, you have an external piece. The whole distractor is outside. You can control the movement, whether you want to go left, right, down, up. All these things are possible, which is not possible in internal distractor. This other distractor that is called as rigid external distractor. So rigid, like a hollow frame. Rigid external distractor. And this is actually very useful for V4 1 level, 2 level, 3 level, as well as prediction from monoclonic distraction. All these things are possible along with V4 2 or V4. Everything is outside apart from certain wires which is connected or connected to the home. Control is better, larger movement is possible. Removal is very easy. That is one of the best advantages of external. Removal is very easy. If you have internal distractor, internal, you have to probably put the patient back on sleep again or general anesthesia, then go for the surgery. That's one of the biggest disadvantages. So remember that this is something which is very important to understand that these things matters that you have got to do. Okay, you have to decide whether previous indication for it. Then there is one more principle of principle. Let us say that you have part of the previous movement. You don't want any fibula or other movement to be there. You can have a transport display. You can keep moving this posteriorly and upward if possible. You can appropriate. Very difficult to not but you can go as much posteriorly as possible. So you are using a disc to travel a long way. That is why it's called as transport distractor. You can distract alveolar bone alone, like an alveolar distractor. What are the indications in distraction during maximum surgery? I finished in a couple of minutes. It's a lower phase in the mandible, mid phase, cranial phase distraction, and like ankylosis. You can probably distraction disease. Okay. Indications in mandible, here are the sequence. You can enter the mandible very nicely, starting from pediatric order. Hemifacial microsomia is very good cases, starting from pediatric. A lot of people are already now by 5 minutes. But then, what other people say that if you can do a pediatric hemifacial microsomia distraction, as the patient becomes heavier, the degree of severity has come down. And we can finish it off with the next week. And remember, distraction is not a replacement for posterior. Distraction is not a replacement for posterior. So you can do ankylosis before or after the release of ankylosis. You can convert distraction, transport distraction, something. In mandible, you have V4 1 level, 2 level, 3 level. Alveolar plastic closure, you can do it. It's a small movement. You have a very big alveolar bone. You wanted to close it like this, perimeter close back. You can do that. Very small distraction. Advanced and front of better than training for the remodel. Lot of studies and lot of people, even in Canada, they do this training for the base of the skull you can remove. So many things are happening. So you can also do syndromic as well as non-syndromic. It's also used in obstructive sleep apnea, syndromic patient like workout, zone, touch-up point. As I already mentioned, a lot of facial blood, post-traumatic deformities, alveolar issues, reconstruction after where you should not use a distractor. Who have no patient inadequate bone mass, infection, eradicated bone teeth, that very elderly patient bone is very soft. And specifically with the road list, unlike in the day like Oxford or seasonal list. So in short, I have to tell you that I was a real big fan of distraction procedures for the last 25 years, but now I have very limited education for in my TP for distraction. I may probably do for management of late or alveolar height increase or increasing the anterior width of the mind. Very limited education. Or for heavy patient. In maxima, the maximum what I have done is for E4 1 advancement, E4 2 level, E4 3 level. Okay, we can also do for distraction of the brain patient state and psychoeducation. So what is important to understand? You have to understand when you read, when you write definition, physiology, anatomy, what is vector, type of distractors, Lorentz clinical. If you know this much, I think it's more than enough. And it's all after that, your clinical experience will matter a lot. You will understand after 10 years of using distraction, okay, this case I will use it, that case I will not use it. This case I will go only with the conventional I can achieve result, and this case probably I need a distraction. I have written an article in our own journal, the comparison between distraction and conventional therapy, starting in 2020. You have to go through it. You will see a lot of idea how to compare a conventional therapy with distraction. Thank you, all of you. Have a wonderful time. Good exam. Come out with colorful.